All right, class, welcome. Today, we're going to enter a war zone, but it's a microscopic one. We're talking about the cellular battleground of anti-cancer drugs. How do we fight cancer? Cell by cell. Cello, let's begin. So let's start with the biggest question, isn't it? How do we fight a war against our own rogue cells? I mean, think about it. These aren't some bacteria from outside. They are our own cells, just gone bad. So our strategy has to be very, very clever. It's not so simple. Okay, so here's our battle plan for today. First, we'll look at the basic strategy, cancer's main weakness. Then we'll cover the imposters, the anti-metabolite drugs. After that, the saboteurs, which are the microtubule agents. Then the DNA breakers, the topoisomerase inhibitors. And finally, the heavy artillery, the anti-cancer antibiotics. Let's go. Right. Section 1, cancer's weakness. What's the basic funda here? We need to exploit its need for speed. See, a cancer cell's greatest strength is that it divides like crazy, right? Well, it turns out that's also its biggest weakness, and that's exactly what we're going to target. And this is the whole game, you see. Most of our traditional chemo drugs, they are what we call cell cycle specific. This means they're designed to attack cells only when they're actively dividing. That's when they are most vulnerable. Especially during the S phase, when the DNA is being copied, and the M phase, when the cell is actually trying to split. We get them right at that critical moment. Okay, on to our first category of drugs, the imposters, the anti-metabolites. The name itself tells you the story. They are trying to deceive the cancer cell's own machinery. Think of them like spies or undercover agents. They go inside and just mess everything up. So what is an anti-metabolite? All right, it's very simple. They are fakes. They are structural analogs, which is just a fancy way of saying they look like the real building blocks the cell needs. But when the cell tries to use these fakes to build new DNA or RNA, poof, the whole production line gets jammed. Nothing works.
And here's a perfect example. Methotrexate, it's a classic. So how does it work? Look at the steps. First, it gets into the cell using the folate carrier. It's pretending to be folate, you see. Once inside, it does its main job. It irreversibly blocks this crucial enzyme, dihydrofolate reductase, DHFRase. Now, without DHFRase, no active tetrahydrofolic acid, or THFA, can be made. And if you don't have THFA, you can't make DNA. The cell is stuck in S phase and it dies. Simple as that.
And one thing you must remember for your clinicals, the side effects of this class. A very characteristic one is this painful rash you can get on the palms of your hands and the soles of your feet. We call it hand-foot syndrome. You see this? You should immediately think of drugs like pemetrexed. All right, moving on. Next, we have the saboteurs, the microtubule agents. Now, these guys don't play spy games. No deception. They attack the cell's internal skeleton directly. They go straight for the support beams, you could say. And what's so fascinating here is that we have two different ways to break the system, and they are complete opposites. You have the vinca alkaloids like vincristine and vinblastine. What do? They prevent assembly. They stop the microtubules from even being built. Then you have the taxanes like paclitaxel. They do the exact opposite. They prevent disassembly. They make the microtubules so rock solid and stable that the cell can't break them down when it needs to. See? One stops building, one stops demolition. But the end result is the same. The cell gets frozen during mitosis and can't divide. All right, listen up. This is a pet question for examiners. Vincristine and vinblastine, they are both vinca alkaloids, right? But their dose-limiting toxicities are completely different. You must know this. For vincristine, think N for nerve damage, peripheral neuropathy. For vinblastine, think B for bone marrow suppression. VNC is for neuropathy, VLB is for bone marrow. Got it? Very, very important. Okay, our next group, the DNA breakers. These are the commandos. They don't mess around with supply lines or infrastructure. They go straight for the headquarters, the genetic code itself. They are here to create fatal errors in the DNA. So, how do they do it? It's actually very clever. See, our DNA gets all tangled up when it's replicating. So we have these enzymes, topoisomerases, whose job is to cut the DNA, let it untangle, and then stick it back together, reseal it. What these drugs do is they let the enzyme make the cut, but they block the resealing part. So you just get more and more breaks in the DNA. For example, etoposide inhibits topoisomerase 2, causing double-strand breaks. Topotecan and irinotecan inhibit topoisomerase I, causing single-strand breaks.
Either way, the result is the same: so much DNA damage that the cell can't survive. And finally, we bring out the heavy artillery, the anti-cancer antibiotics. Now wait, don't get confused. These are not for treating infections. They are powerful agents, many derived from microorganisms, but they have unique risks and are used to kill cancer cells. And with great power comes very specific toxicities. You have to remember these. This is non-negotiable. Doxorubicin, high risk of cardiotoxicity, heart damage. Bleomycin, high risk of pulmonary fibrosis, lung scarring. And mitomycin C, it causes delayed myelosuppression. These are not your usual side effects. These are unique signatures of these drugs. So, let's just take a step back. What we've discussed so far, these are the classic weapons. They're powerful, yes, but they cause a lot of widespread destruction. They don't just kill cancer cells. They hit any rapidly dividing cell. But you know what? The battlefield is evolving. And this is the bigger picture. The future is moving beyond this widespread destruction. We're moving towards targeted therapy. Instead of carpet bombing, we are developing smart bombs, drugs that attack specific molecules that are unique to cancer cells. A famous example is the drug that targets the BCR-ABL tyrosine kinase, which is only found in chronic myeloid leukemia cells. It's a precision strike. Which brings us to the final question. The dream, really. What if we could design a magic bullet? Something that could hunt down and kill only the cancer cells and leave every single healthy cell in the body completely unharmed. That's the ultimate goal, isn't it? A therapy with maximum power and zero side effects. We're not there yet, but we are getting closer. And we'll talk more about that next time. Hello, class, and welcome. Today, we're going to dive into one of the most complex, most important topics in all of medicine: the strategic battle against cancer. We're going to break down the entire chemotherapy battle plan, from the old-school blunt force methods to the new precision strikes. So this is the fundamental question, isn't it? This is the core challenge of all cancer therapy. We're not fighting some bacteria or a virus that's come from outside. No, the enemy is us. Malignant cells are our own cells. They've thrown out the rule book and started growing and dividing completely out of control. So to understand how we tackle this enemy from within, here's our plan for today. First, we'll see why cancer is such a different kind of enemy. Then we'll look at the main battle plan. After that, we'll explore the new weapons in our arsenal, the targeted and hormonal drugs, and finally, and this is very important, we'll talk about how we manage the side effects. All right, first up, understanding the enemy. You see, the biggest problem with chemotherapy is that cancer cells are, at their core, our cells. This makes it incredibly difficult for our drugs to tell the difference between the bad guys and the good guys, between the cancer cell and the healthy tissue right next to it. And this lack of selectivity, that's the central challenge we're always trying to overcome. And here's something you must never forget. Unlike a normal infection where our immune system helps clean up the mess, with cancer, we're pretty much on our own. To get a cure, we have to eliminate every single malignant cell. If even one, just one, is left behind, it can regrow the entire tumor. The goal isn't just to weaken the enemy, it's total annihilation. So, if the goal is to kill every last cancer cell, what's the master plan? How do we design an attack that's deadly to the tumor, but, spares the patient as much as possible? Let's break down the actual strategy. Now have a good look at this graph. This single picture, it basically lays out the entire playbook for modern chemotherapy. It shows you the number of cancer cells over time, and these lines, A, B, and C, they represent our main strategies for getting that number all the way down to 0. So look at path A. This is our most successful approach. We hit the cancer hard with a combination of drugs. Then we pause. We give the body a rest, let the normal cells recover, then we hit it hard again. It's cyclical. Now look at path C. This is what happens if you just use one drug. The cancer cells, they're clever, Yar. They adapt, they develop resistance, and then, boom, the tumor comes roaring back. That's a failed strategy. Now, to execute this battle plan, we have two main types of drugs, our soldiers. Think of the cell cycle non-specific, the CCNS drugs, as your heavy artillery. They cause damage whether the cancer cells are actively dividing or just sitting there, resting. Then you have the cell cycle specific, the CCS drugs. These are your snipers. They only target cells when they are in the vulnerable process of dividing. You need to combine both for the most effective attack. Okay, now let's talk about the modern arsenal. For decades, chemotherapy was kind of like carpet bombing a city. Yes, it's effective,
but you get a lot of collateral damage. The new generation of weapons, though, these are targeted drugs. These are like precision strikes, designed to hit unique features that only the cancer cells have. First up in this category, we have angiogenesis inhibitors. The concept is actually very simple and very clever. For a tumor to grow beyond a tiny little speck, it needs its own blood supply. It needs to build blood vessels. So what do these drugs do? They stop the tumor from building new blood vessels. You're basically cutting off the enemy's supply lines, starving it of nutrients and oxygen. Here are a few key examples. And notice the different ways we give them. Bevacizumab is a big molecule, an antibody, that works outside the cell, so it has to be given by IV infusion. But sunitinib and sorafenib, they're small molecules. They can get inside the cell to do their job, and that means the patient can just take them as a simple tablet. Now for another really smart approach. Every cell, including a cancer cell, produces waste, proteins it needs to get rid of to survive. So, what if we could just jam the cell's garbage disposal system? What if we could make it choke on its own waste? And that is exactly how this drug, bortezomib, works. It's a proteasome inhibitor. It literally jams the cell's garbage disposal unit. All the toxic junk proteins build up and up and up until the cell has no choice but to trigger its own self-destruct sequence. We call this apoptosis. It's a very elegant way to make a cancer cell commit suicide, especially in diseases like multiple myeloma. So next up is a completely different class of drugs, the hormonal drugs. Now, listen carefully, these are not cytotoxic. They don't directly kill cells like the others we've discussed. Instead, they use a very special tactic for cancers that are, well, addicted to hormones to grow. So think of it like this. Certain breast and prostate cancers, they feed on hormones. Estrogen or androgen is like their food. So what do? We cut off their food supply. We use drugs like tamoxifen, which is an anti-estrogen. It blocks the receptor so the hormone can't get in and tell the cell to grow. We're essentially starving the tumor into submission. Now, we've talked about all these powerful drugs, but using them always comes with a cost. There's always going to be collateral damage. So managing the toxicity, the side effects, is just as important as killing the cancer itself. And to manage all this, we have our key rescue agents. To protect the bladder from a particular drug, we use Mesna. To control that horrible nausea and vomiting, we have powerful drugs like ondansetron. And to help the body's white blood cells recover so it can fight infection, we give agents like filgrastim. These support drugs are what make it possible for patients to tolerate the high doses of chemo we need to destroy the cancer. So what's the key takeaway from all this? Our approach is evolving. We're getting smarter, we're getting more precise, moving from brute force to these very targeted tactics. Which leads me to a final question for you all to think about. Are we slowly shifting away from an all-out war on cancer to a future where many cancers can be simply managed as chronic diseases? Much like we manage diabetes or hypertension. It's something to ponder.
All right, everyone, settle down. Namaste. Today we are going to talk about something very, very important. Not just for your exams, but for your whole career, really. Immunosuppressant drugs. These are the real heavy hitters in our field. So let's get right into it.
Okay, so here's how we'll break it down today. First, we'll tackle the main problem, the why behind all this, the transplant dilemma. Then, we'll go one by one through the big drug classes you absolutely have to know. Calcineurin inhibitors, the mTOR inhibitors, and then the cytotoxic drugs. And at the end, we'll see how they all fit together in your, let's say, your immunosuppressant toolkit. Sounds good? Let's go. So, let's start at the very beginning. Why? Why do we even need such powerful and, let's be honest, sometimes dangerous drugs? What is the basic problem we are trying to solve here?
And here it is, the central paradox of transplantation. You put in a new, life-saving organ, a kidney, a liver, but what happens? The body's own defense system, the immune system, looks at this beautiful new organ and thinks, hey, you're not from around here. It sees it as an enemy, a foreign invader, and it launches a full-scale attack. We call this rejection, and our entire job, our #1 goal, is to stop this from happening.
All right, so let's look at our first weapon in this fight. It's a major one. We're talking about a class of drugs called calcineurin inhibitors. And within this class, we're going to focus on the king, the main player you will encounter day in and day out, tacrolimus. So you might be asking, why is tacrolimus the go-to drug? Well, first off, it's a beast, a really powerful immunosuppressant from the macrolide family. It's generally preferred over the older one, cyclosporin, simply because it's stronger. It's better at shutting down that initial acute rejection. And here's a little clinical gem for you, something to remember for your Vivas. It's super valuable in liver transplants. Why? Because its absorption doesn't need bile. That's a huge deal. Don't forget that point.
Okay, now listen up, Butcho. Put your phones down for this one. This comparison table, this is pure exam gold. I guarantee you'll see this somewhere. The examiners love asking about the side effects, so you have to know this. With tacrolimus, you're looking out for things like diabetes and neurotoxicity. But with cyclosporin, it's a different story. You get more hypertension, hirsutism, that's, unwanted hair growth, and that classic gum hyperplasia. You have to know this table inside out.
Okay, good. Now that we've covered that, let's move on to the next level. We're going to look at a different family of drugs now. And these guys have a really clever way of working. We're talking about the mTOR inhibitors. So, what on earth is mTOR? It's a bit of a mouthful, right? It stands for mammalian target of rapamycin. But forget the name for a second. Think of it like this. Imagine your T cells are workers in a factory. mTOR is the factory manager, the guy who shouts, "Okay, everyone, start multiplying. Go attack that new organ." What these drugs do is, well, they don't bother fighting all the individual workers. They go straight for the manager's office and shut him down. Very clever, no?
So let's look at how it actually works, taking sirolimus as our example. Now, interestingly, it starts by binding to the same protein that tacrolimus uses, this thing called FKBP. But, and this is the key difference, after it binds, the new complex doesn't go after calcineurin. No, it targets and blocks mTOR instead. So you see, tacrolimus works a bit earlier in the chain of command, while sirolimus blocks things a little later. It's a different weak point in the same pathway, which gives us more options.
Now look at this number, 60 hours. That is the half-life of sirolimus. Think about that for a second. That is incredibly long. So what does that mean for us as doctors? It means that when you start a patient on this drug, it takes a very, very long time to build up to a stable level in their blood. And that means we have to be super careful and monitor their blood levels like a hawk to make sure we're not overshooting and causing toxicity.
And here we come to the biggest selling point of sirolimus. This is a huge deal, clinically speaking. It is not nephrotoxic. It doesn't harm the kidneys. Now remember what we said about tacrolimus and the other calcineurin inhibitors? Their biggest problem, the thing that limits how much we can give, is kidney damage. So if you have a patient whose kidneys are starting to suffer on tacrolimus, what can you do? You can bring in sirolimus. This is an absolute game changer in managing these patients long term. Okay, so here's a quick look at the whole mTOR inhibitor family. You've got sirolimus, the original one we've been talking about, and then you have its younger cousins, everolimus and temsirolimus. Just notice a couple of things. The newer ones have shorter half-lives, which can make them a bit easier to handle clinically. And also very interesting, they've found a second life in oncology. They're being used to treat certain types of cancers. So the story of these drugs is still evolving.
All right, let's shift gears. We've talked about some of the newer, more targeted agents. Now let's talk about the old guard, the reliable workhorses of immunosuppression, these cytotoxic and anti-proliferative drugs. Their strategy is a bit more blunt. Their main job is to just stop the immune cells, the T and B lymphocytes, from multiplying. They basically prevent the army from even being assembled.
And in this group, there are 4 big names you need to know. You've got azathioprine, which basically messes with the DNA production line. Then there's methotrexate, which starves the cells of a key nutrient they need to divide. Cyclophosphamide is interesting because it tends to hit B cells a bit harder. And then there's mycophenolate mofetil, or MMF as we all call it, which is much more selective. Let's dig into that a little bit.
So this table gives you a nice summary of their targets. Now, I want you to focus on MMF for a moment. Why do we call it selective? It's because of a beautiful bit of biochemistry. You see, MMF blocks a specific pathway for making purines, the building blocks of DNA. Now, most cells in your body have a backup plan, a salvage pathway they can use if this main one is blocked. But, and here's the genius of it, your T and B lymphocytes don't have that backup. They are completely dependent on this one pathway. So when you block it with MMF, you hit the immune cells very hard, while leaving most other cells in the body relatively untouched. That's why it's such a great drug.
Okay, we've looked at all these different classes, all these different mechanisms, so now for the most important part. How do we put it all together? As a future doctor standing in front of a patient, how do you use this knowledge? How do you build a treatment strategy?
The most important principle you need to understand is this. We almost never use just one drug alone. Why? Because to get enough immunosuppression from a single drug, you'd have to use such a high dose that the side effects would be terrible. So the standard of care is always combination therapy. It's like making a cocktail.
Your main ingredient, your foundation, is usually a powerful calcineurin inhibitor like tacrolimus. Then you add an antiproliferative, maybe MMF, which allows you to use less tacrolimus and spare the kidneys. Speaking of kidneys, if they start to get into trouble, you might swap in an mTOR inhibitor like sirolimus. And of course, you almost always have glucocorticoids in the mix to keep inflammation down. It's all about teamwork, using different drugs with different mechanisms to get the job done while keeping toxicity as low as possible. So, there you have it, a whirlwind tour of the most important immunosuppressant drugs. But before we finish, I want to leave you with a question to think about. We're getting better and better at this, right? Our drugs are getting more precise, more targeted. So what's next? Where are we headed? Is there a future where we can fine-tune the immune system so perfectly that chronic rejection becomes a thing of the past? A future where transplantation is truly personalized? That's the challenge for your generation. Think about that. Okay, that's all for today. Thank you, everyone. Study hard.